Good morning, everybody. Today we are.
Sir, please wait.
Okay.
We are going live in 5 seconds. 5, 4, 3, 2, 1. Now, sir, we can start.
Thanks. Good morning, everybody. Today we'll start with the third session on the techniques in pediatric orthopedic trauma. Today's session on radial neck fracture techniques. One second. So the first talk we have changed the order. First talk will be taken by Molan sir on the close reduction technique for radial neck fracture. And then the second talk will be taken by Virat sir on close reduction and Matthew technique. And the third talk will be by Sandeep sir on intrafocal pinning for the radial neck fractures. I'll just introduce our faculty and then we'll start. Virat sir, he's the director of Children Orthopedics Care Institute, Pravira Hospital in Nagpur, and he's also the secretary of the Pediatric Orthopedic Society of India. After doing his MS and DNB orthopedics, he did his pediatric orthopedic training from UK and South Korea. Sir has pioneered many surgical techniques, especially in neglected clubfoot, radial ulnar synostosis, and CP. And he's also the recipient of Best Clinical Research Award for these surgical techniques. He's also been recognized by the government of Maharashtra as the best person working in childhood disability. And Sandeep sir, Sandeep Patwardhan sir did his MS orthopedics in 1995 from Sion Hospital, Mumbai, and then he did his fellowships from Singapore, Germany, and in USA. And he heads the pediatric orthopedic unit in Sancheti Hospital, Pune. And sir is involved in pediatric orthopedic training and teaching and research via IFIX and various trauma courses and the POSI events. And we want to thank our faculty for taking their time and accepting our invitation. So we'll start with our first session on close reduction technique. Molan sir, you can please share your screen.
Yeah, I think, did you stop sharing?
Yes, sir, I'll stop.
Hi, Viraj.
Good morning, Molan. Good morning, James.
Good morning, sir.
Yeah, so there are a few videos in this, and if it does not play well, then I'll move out of the window and restart and all this. So we are going to talk about displaced radial neck fractures. Now, this kind of completely toppled off radial neck may have 4 options: close reduction, K-wire assisted joystick or intrafocal pinning, which Sandeep is going to talk, Matthew's technique, Viraj is going to talk, and open reduction. For very long time, people were thinking that this most severely displaced fracture would need something intrafocal or in rare instances open reduction, but we could develop and close reduction techniques, which I'm going to talk about. Conventionally, the Jude classification is used to assess the displacement and severity of radial neck fracture, where type 1 and 2, where the angulation is less than 30 degrees, it can be conserved because of remodeling potential. When it is between 30 and 60 degrees, a close reduction can be tried with different maneuvers and methods. But when it comes to type 4, where the angulation is more than 60 degrees, all this conservative treatment had failed. And so either a percutaneous or open reduction with instruments or implants have been tried. And these techniques are many close reduction techniques, Peterson maneuver, Kaufman or Israeli, Nahar Torch, and so on. But if you read these papers, this is true for Jude 2 and 3, and none of this uniformly achieved anatomic reduction Jude type 4. In this Orthokids technique of close reduction, we are going to discuss close reduction for Jude type 4A and B. And thus, it means that for type 2 and 3, we can definitely use this technique. We are interested more in most severely displaced radial neck fractures. So first, let's see the technique at a glance through this media. If it plays, else I'll go out and show you. Yeah. So this animation is extremely good, which will So for a moment, I'll stop sharing this screen and I'll show the video from outside. Yeah. So I'll just make a full screen.
Connected to 30.
Anyway, so what I'll do is I'll open the folder and play those videos. But biomechanical basis of this reduction technique is that we try to use ligamentotexis to reduce the radial neck fractures. And thus it means that the ligament should be intact and there should be isolated radial neck fracture. If there is an associated elbow dislocation, then many a times these ligaments are torn and this technique may not work. So let me open the folder. Give me a minute and sorry for this. Yeah. So you can see now, right, Joannes?
Yes, sir.
Yes,
So
sir.
this is an animation which shows that the first step of this injury or reduction technique is to see the radial neck in profile. And so you have to maneuver or rotate the forearm in different angles under image intensifier. And this suggests when you see as a rectangular piece, that's a profile. And this is the position in which the fracture would have happened. Then you give the varus force by giving counter pressure from the elbow and give longitudinal traction. And then with the thumb, you give manual pressure on the radial head and convert a type 4 to type 3. And the final step is you flex the elbow in pronation, which would align the radial head completely anatomically. I'll replay this. So the first step is to visualize the radial neck in profile. Is it not progressing? It started. Yeah. So most of the times you need a bit of pronation more than full supination, and you see the rectangular piece. Then you give varus force by the counter traction. Once you do the varus force, the lateral recess opens up. You give longitudinal traction, and then you push with your thumb. You locate the radial head both in AP and lateral view, and then with the final pronation supination maneuver, pronation and flexion maneuver, the annular ligament and all these collateral ligaments become tight and it reduces fully. So this pronation is very important. And now I'll show you this technique on a patient. So so this is a 6 years old patient with Jude type 3 radial neck fracture.
Step 1. Positioning on radiolucent table.
And
Patient
this is
is
with my
placed in
commentary on
supine
JBJS,
position
so you
on
can
table.
listen to it and we'll talk about it
A
later.
separate radiolucent arm table is used. Step 2. To view the radial head in profile. Degree of forearm rotation is identified under image intensifier to localize the maximum angular displacement. The forearm is placed in position where the radial head is seen as a rectangular piece under the image intensifier. This is the pre-injury position of the forearm. In this position, further reduction maneuver should be performed. Step 3. Longitudinal traction. In the forearm position where the radial head is seen in profile, longitudinal traction is applied by the surgeon by holding the distal forearm, and counter traction is provided by the assistant through propers. Assistant should give counter pressure on the medial side of the joint line while the surgeon simultaneously gives traction and varus force. This maneuver distracts the lateral joint space. Step 5. To locate the radial head and thumb pressure application. Now the surgeon should locate the radial head in both the sagittal and coronal views with the help of image intensifier, a persistent fragment with the distal fragment. Step 6. Flexion pronation maneuver. Once the radial head is partially aligned with the metaphysis, the surgeon flexes the elbow and simultaneously pronates the forearm. This maneuver obliterates the posterior and lateral joint space and aligns the radial head anatomically with the metaphysis. Step 7 is confirmation of reduction on image intensifier. At this stage, the reduction of the radial head should be checked in both the coronal and sagittal views in the full range of elbow flexion and extension, keeping the forearm in pronation position. The anatomically aligned radial neck does not need any form of fixation. Step 8. Plaster application.
So the plaster is applied usually in pronation a bit more than mid-prone, and you have to check your position, that in which position the radial head remains completely reduced. What I have seen that the moment you reduce and supinate, there will be a lateral translation, so you want to avoid that. So radiologic correlation, this is AP view of elbow of the same fracture which I had shown in the first. After longitudinal traction and thumb pressure, we converted type 4B to type 3, and with flexion pronation maneuver, it got completely reduced. And this is 1 year follow-up.
Sir, your screen you have to share.
Oh, the screen is not seen. Okay, I'll do it in a moment. Yeah, now is it visible now?
Yes, sir.
Yeah. So this is the for 1 year follow-up of that child which I was talking, and this is one more example. 4B. This is most completely toppled off, as you can see. And again, we could reduce with the same technique, and it does not need any implant fixation because it is very stable. We keep plaster on for 3 weeks, and that is enough. Sometimes you will come across very young children with partly visible radial head. This is 3 years old, and the injury was 5 to 7 days old. So it was very stiff. So what you can do is you take contralateral X-ray and that shows the radial neck. Then you do an arthrogram, which would outline the radial head. So you know this is Jude type 4 injury. In this case, it was moving together, so it was partly stuck. And so I did intrafocal K-wire, blunt K-wire assisted or kind of osteoclysis. And once it was done, it got reduced completely, and we reduced with our technique, and it was immobilized in pronation. This technique has been published in Indian Journal of Orthopedics and in JBJ's Essential Surgical Techniques as well. So you can have a look, and I'll share those techniques with you. So I think I finished my talk here. Where it does not work is this, the Jeffrey type fractures like this fracture, who had associated elbow dislocation. We tried to reduce it, and I found that elbow is dislocated, and I could not, we could not reduce it. And then we required open reduction in this case. Right, so I'll stop here, and I would like to have questions if they are there. Yeah, good morning, Sandeep bhai. So for last 7-8 years, I have not done intrafocal or metazu for isolated radial neck fracture at our center. And every now and then I receive feedbacks from colleagues who are doing this, and they are very happy because conventionally we used to fix them. Now you don't need to fix them.
Maureen, can I ask you the question?
Yeah, please.
Yeah. So this the pronation principle is same, like what is the periosteum acts like a hinge or it gives stability. Is it the same principle you are using for the
Here
pronation?
it's not periosteum, but it's the ligament. The
Mhm.
radial neck position is controlled by radial and ulnar collateral ligaments
Right.
and the annular ligament. So
Correct.
when we supinate the forearm, these ligaments become loose and the radial head can translate and angulate. But the moment you align it partially and then you flex it, you are tightening the posterior capsule. So posterior recess is closed, and then you pronate and flex. So all these ligaments become tight and it will reduce the radial head anatomically. And in this position, you flex, extend in AP and lateral, you see the radial neck will not move. So you just plaster it, and in 3 weeks time, you remove it. So we have done now around 30-35 cases where at 1 year follow-up, they all resumed full supination and pronation. So we had a fear, like Sandeep would say, that if you immobilize in pronation, they will lose supination. So Sandeep, I have not seen this in these radial neck fractures. In forearm, I have done your approach. In 2 weeks, I'll come back and convert in supination plaster. But for radial necks, we keep it for 3 weeks and then they resume the movement. That is the position needed to, anatomically align it.
Okay, thank you, sir. Sir, as of now, there are no questions.
Yeah.
So we can proceed to the next talk. Virat, sir, you can share your screen, please.
Yeah. Yeah. Is it visible, Maureen?
Yes, sir. Yes, sir. Yes.
Yeah. So thanks, Maureen, for inviting me for delivering this lecture. So Maureen has demonstrated an excellent method, his own technique of how do we reduce the fracture. Now, this technique, which I'm going to speak about, is Metezio's technique. Is a French person who has established this technique way back in 2005. He published in Injury Journal. So basically, as Maureen has mentioned, that these fractures, if they are presenting around 30 degree or maybe 40 degree of angulation, they many times they remodel very well and they don't require any kind of reduction maneuver also if the child is small. But if the angulation is more than 40 degrees, and what we all know that if we try to openly reduce these fractures, there are very high chances of AVN because the periosteal, the blood supply goes from the periosteum, that metaphyseal area, because the top portion is completely covered by the cartilage. So it is only the metaphyseal area where the periosteum is there, and from there only there is there blood supply. So we should try to preserve the blood supply as far as possible, and for that only, most of the authors now agree that if you can reduce this fracture by any kind of close methods like Mollin's technique, or maybe what Sandeep is going to speak about, or this Matizio's technique, nothing like it, because it gives the best function to the child, right? So this, what is this technique, Matizio's technique? In his technique, it is we have to introduce first the nail or the K-wire. Here use the K-wire basically, like similar what we do for the radial shaft fractures. So you take a K-wire, approximately around 1.2 to 2.5 millimeter diameter, and then you contour it. The tip you have to contour or bend little more, because you are going to get the alignment for the fragment, the fracture fragment for that. Take a 1 centimeter skin incision at the distal radial metaphysis, as we take for any radial nailing, for the tense nailing what we do. While taking the incision, your incision has to be 1 centimeter proximal to the physis, that is the distal radius physis. You have to go little proximal to that. Dissect out the soft tissue, preserve the superficial branch of the radial nerve, go up to the bone, then make either with the help of the awl or you can with the help of the drill, you just make an entry point. Now the entry point is approximately around 2 centimeter proximal to the growth plate or the distal radius physis, right? So you are going little proximal to the physis so that you're not damaging, or your nail tip should not damage the physis in the future. And then you introduce the nail or introduce the K-wire, and then you go proximally. So once you go proximally, this is the original diagram from his own paper, Matizio's paper. You gently hammer the K-wire or nail which you have put, and then that K-wire engages the proximal fragment over here, and then again gently you tap it, or you can just hammer it, or you can introduce more so that it lifts the fragment like that. So maybe some kind of destructive force you are applying, and once you have applied this, then once you are entered into that, and then you have to rotate the K-wire by 180 degree. So you rotate the K-wire or your nail which you have introduced by 180 degrees. So that should reduce the fracture like that. Okay. That is a technique which is in original paper, Matizio has mentioned, and he has demonstrated radiologically as well. So here we have put the nail, and then that has engaged the fragment of the radial head over here, and you keep on little distracting, or you can hammering or advancing your nail, and then you rotate it completely here, so it reduces the fracture. And this is the lateral view which is there. So you have to immobilize the arm in a slab for 2 to 3 weeks. You take off the slab after 2 to 3 weeks, and then you have to start mobilization, and you have to remove the pin after 8 weeks. That is what he has mentioned in his original paper. So this is how we take the incision. Now I'm using this flexible nail. So tense nail, what you can say, you can use a long K-wire in whichever way, it is available with you. So when you introduce it, you have to be proximal to this is a distal radial growth plate which is there. So you have to prevent any damage to that, and then you have to be proximal over here, and then you introduce like that. Okay. And once you are introduced, see this video where now this after introduction, and once you reach to the fragment, you still keep on advancing gently, so that you're not gently you're going advancing, and then once you are engaged it nicely into the proximal fragment, then you rotate it by 180 degree. Sorry for this, not maybe very good kind of image picture. Then you rotate the nail by 180 degrees so that the the fragment is reduced nicely. You can see now, right? So that is the original technique what Matizio has described. But if you are not able to achieve the reduction like this, like the cases like this, where suppose you have tried Moulin's method and you have tried to introduce the nail and try to disengage this fragment, and then you are not able to get the reduction. So what next? There are certain tips I would like to mention. Many times we try with the Ishmael bandage. It works beautifully. And then joystick assisted technique, which maybe Sandeep is going to speak more about that. You can use a simple mosquito forceps also by just giving a small nick if you're not, so that you are preserving the vascularity and periosteum. This is an example of use of Ishmael bandage.
Sometimes it helps in the radial, so we just tightly tie the small band.
It works beautifully. This is an example where in this patient, the reduction was not coming, and with the Ishmael band you can see it has reduced, and this is a follow-up you can see, right? And then we have to pull out the nail. Joystick assisted reductions, like Moulin also has mentioned, there is no harm in using a simple K-wire like this to get the radial head into its position. Sometimes you can use a mosquito forceps like this also. And sometimes, very rarely, if the displacement is very severe and you are not getting, sometimes you might use 2 K-wires also as a joystick to reduce it. These are the case example. Kind of severe displacement, you can see here from this here the fragment has moved like this over here. So manage with the
wire, you can see the of the radial movement.
So with this, now see, it was reduced like that. And this is a follow-up. You can see there is good union at 2 months. Now this is an example of 2 KYS where it was not coming. Sometimes this was a little old injury. She presented at 7th day of the trauma. And then we have to use a 2 KYS to get the reduction. This is how we inserted the nail. And this is how we are getting the reduction. And you can see the entry point which is there, and hardly there is just a puncture wound of joystick. Right? That is KVAR we are used for the management. This is we have reduced the fracture closely, and this is the entry point of the radius nail. So with a small with this mini needle technique, see the post-op image now. It has reduced very nicely, and this is a 3 month, and then see the alignment which is there. So these kind of severely displaced fractures also can be. This is after nail removal. She had a full function. So they usually have very good function, you know, the full rotations, and then so in summary, Matisios technique or mini-invasive technique, they work wonderfully. If you preserve the vascularity, you are definitely going to reduce the chance of AVN. They give good results, and it does not require any kind of special training. Any orthopedic surgeon who's good enough subject-wise how to reduce and align, I think they work very beautifully. So thank you all for the kind attention. Any questions, I can answer them.
Yes, sir. So there's one question from Dr. Tashwin. He's asking if patient comes after 14 days of injury, which procedure should we use?
14 days.
Yes, sir.
Yeah, I mean, 14 days is really difficult to get with mini-invasive or maybe kind of from by the close. You can try. I mean, but if you are not getting, just making a small nick and then try to reduce with the help of mosquito forceps, as I mentioned, or maybe kind of a dura retractor you have small, that can help to some extent. If at all it is not possible, then fracture is very severely displaced, then you have no choice. You have to go for the open reduction.
So another question from Molin sir. When do you start mobilizing after Matsu technique?
Yeah, usually I started after 3 weeks. So in his original paper, he has mentioned 2 to 3 weeks is a time when you start mobilizing the elbow. And you have to pull out the wire after 8 weeks. So minimum 8 weeks he has advised to keep the wire over there or the nail over there.
Yeah, so like, you know, some people, they would say that we do Matisiu because we can start early mobility. But usually in practice, you know, most of us, they after Matisiu, they mobilize after 3 weeks, even for the isolated injuries. So for the next time, you can try our technique, Viraj.
Yeah.
Whatever displacement is there, if it is stable, then there is no need to put implants. And anyways, you have to immobilize for 3 weeks. And in a year's time, none of them have restricted movement. So why to, you know, we had this resistance, you know, that is Matisiu has explained, then it can be treated only with some sort of implant. It will be unstable, but it is not like that. So you do it, and then you'll be very happy that we can fix it without.
Yeah, so I agree with Molin. So basically, orthopedic is a subject. Whenever if best what you can do for the child, you know, for any child for any fracture, that will I will say. And as far as mini invasive way or by the close method, if you can do nothing like it, but that doesn't mean that it's a blank. It is not a blanket statement that for everything you have to go close. It is not like that. Even Molin will agree with that. So if you are able to achieve it, the good reduction and good function, nothing like that. If you're not comfortable, there is no harm in going and for the other techniques.
What I agree, what you said. What I mean to say is that mental block that this is severely displaced, so it cannot be closed. That should be removed.
Yes. 100%.
And for anything to that, we should have faith in that technique, you know.
Yeah.
Anyways. Yeah.
Thank you.
Thank you, sir, for the talk. We don't have any further questions as of now, so we can proceed to the third talk. Sandeep sir, you can share your screen, please.
Can you hear me?
Yes, sir.
Okay. Maulin, if you don't mind, I have two small presentations.
Yeah. You take
One
your
is
time.
about the technique, second is about some complication and its management, which somebody asked a question, delayed presentation.
Yeah, so and in this Matizu and those all have some complications. So anyway, so you can talk.
You will be surprised, even close reduction has complications.
Yeah.
I'll show you that. Doing nothing also has complication. Okay, can you see the screen?
Yes, sir.
All right, so just this is something which I was doing since 2006. I think through all three talks, what you'll realize for radial neck fractures is that it's a very, very delicate fracture. And number two is that you need to know what is acceptable and what is not. Right? So all of you who are starting off in your pediatric trauma practice, please remember radial neck fracture, metaphyseal fracture is usually Salter 2, rarely Salter 3. If it is associated with dislocation, it's a very complicated issue. That's a totally different ball game, as Maulin Bhai has already said. And trying to get an acceptable reduction, which the body can remodel, is the aim. It need not be a perfect reduction all the time. Right? So most of the radial neck fractures which have 30% translation, 30% angulation, it's a rule of 30s, can be accepted, especially if the child is younger and they will remodel pretty well. But if it is displaced, you need to bring down that angulation or displacement to less than 30%. And then you will have a good result. So after you start with either the Eschmark bandage or Maulin's technique, and if you get a satisfactory reduction, I totally agree that the periosteal hinge locks very well, and in flexion, the radial head is stabilized between the shaft and the capitulum in 90-degree flexion, and implants are not needed. But if you are struggling to get a reduction, you can use an intrafocal pin for managing this kind of a displacement. So it's a selected group where there is lateral angulation, minimal combination with an intact head. And it essentially means that you enter, like Sof Kapanji, lower end radius, you enter the fracture site from just next to the ulna, posterolaterally, and then go into the fracture and use the K-wire to joystick and lever the proximal fragment into position. And then just pass the wire into the shaft to engage the cortex such that it is buttressing the radial head. So there is no separate implant here. It is that simple K-wire which is holding it for some time. And then in about two weeks in the OPD, you give a plaster, and in 2 weeks in OPD, make a window and pull that wire out. It's a temporary stabilization along with the reduction technique. So this is an example where you have angulation which exceeds about 30 degrees. So I need to bring this aligned to the capitulum. So this is a Siam shoot. On the skin, I've kept the wire just to have an orientation as to at what level do I need to enter the fracture. And then we pass the K-wire in such a way that it goes directly into the fracture. We are not manipulating the head. Target the fracture site. And I have seen quite often that it is the shaft which moves towards the ulna, towards the interosseous membrane. So you have to just lever it out, and with that leverage, fulcrum is on into the fracture, you will get the reduction. And the same wire, so I do this on a T handle. It's a 2 mm K wire on a T handle. And then you elevate that, and just gentle rotations, you will engage the opposite cortex. And then you leave that wire outside, bend it a little bit so it doesn't move, and give a plaster. So this is what we do, and that is how it heals. And you will get a decent result. This is another case just to show the same technique. I had published it in Maharashtra Journal of Orthopedics in 2006. So pretty long ago. After that, we have not written much about it. And this is another way case where we have done, I think, an arthrogram also. No, this is no arthrogram. So again, reduction, intrafocal reduction, and the same K-wire holding the cortex. Yeah, this is the arthrogram. Again, you can see that I've always seen that the shaft moved toward the ulna. Okay, the radial head is pretty much there, but something is obstructing, and you need to get that shaft back under that metaphysis of the radial neck. So you put the K-wire there, bring it back. You have the arthrogram, which can help you as a guide. Does pretty well. So it's the use of K-wire as a leverage to get a reduction as well as a temporary stabilization. If you feel it is unstable, Metazo technique can be added to hold that fragment and mobilize early. But we all agree that the use of open techniques is not really a good idea. It's pretty easy and you can try it in your practice after you have first done simple close reduction maneuvers. Patterson's method or Mollin's method or Eschmark method doesn't matter. The idea is to do it close, preferably not to disturb the hematoma and not damage the periosteum and vascularity, because otherwise you can get problems. Now, somebody asked about delayed presentation. So this child came to me after 3 weeks. So this is a 3-week-old. You can see calcification there and some kind of attempt at healing. And this was totally it is more than 90 degrees. It just toppled off. So here what we did was we used both techniques because it was not possible to do any close reduction at 3 weeks. So what we did was I used the joystick method and reduced the angulation as much as I could I could use the KY to softly break the callus. And then going into the fracture, I tried to maneuver that fragment back into position. And we got a reasonable reduction in the earlier 90-degree to I brought it to maybe 45 or 50 degrees. And then I used the Metazu technique because I was not getting the full reduction just by this. So then I used the Metazu technique. You can see the wire here. And again, Metazu is not very simple. Viraj has showed you nicely a 2 mm tens nail or a wire with a bend here to maneuver it. The proximal fragment is really, really small and metaphyseal hold is not very, very solid. So it is necessary. I also agree that 3 weeks of casting is necessary. But again, this is a tool. You can use that curve to gently tease that head back into a better position so that your reduction is held and eventually pass it. Might take some time, but eventually you should be able to pull that fragment after doing it a couple of times. Also use thumb pressure simultaneously to push that in and create some varus so that you open up the lateral side. And gradually, with a little patience, you can get that reduction. Yeah. So this is finally after I was happy, and I then hammered that you can't really have hold unless you punch that into the metaphysis. Then you hold it and then give a plaster for about 15 days to 3 weeks, which should be sufficient. And that is how we got the reduction. And that is the final X-ray and healing. So even in the old fracture, it is a nice idea to try to be as minimally invasive and conservative as possible. So it should not be that I will follow X technique or Y technique or Sandeep's technique or Viraj technique or Moulin technique. Understand the principle, bring down the angulation and displacement to what is acceptable. Do it by the closed method or use minimally invasive techniques and use a plaster. As Colin has said, it doesn't cause much of stiffness at all. So that is not really an issue. And this I will show you some interesting cases that came to me and just to highlight the complications that can happen. So you can see this 9-year-old girl who was treated in a plaster slab. You can see that this looks quite acceptable. Pauline, you agree? This is not a bad.
संदीप तेरा वो स्टॉप शेयर करके फिर करना, ये दिख नहीं रहा है.
दिख नहीं रहा है.
हाँ, वो ये फिर तो ये स्टॉप करके दूसरा शेयर करना.
Okay, I'll share. So yeah.
पहले संदीप भाई, just
can you see?
Yeah, we can see now.
Okay, yeah.
Yeah.
Sandeep,
So
you want to take some questions about this technique first?
No, we'll do it together. I'll just finish this. Yeah. So this 9-year-old girl, no, she came with X-rays to me. She had come for a different problem, which I'll show you. So do you think this is acceptable, Maulin?
She's 9 years old girl, right?
Yeah, 9 years old. This is the fracture.
Does
This
she
was
have
treated.
how much after the treatment?
No, she came to me for something else. So this was her first.
No, what I mean to say is what time has elapsed from the index injury? That's
Now it is about 4.5 months.
so.
But this was her primary X-ray, which to me looked pretty reasonable.
Okay,
It
yeah,
is not
yeah.
badly displaced.
The only thing is it is not showing healing, which we
No,
usually.
this was the fresh X-ray. That's what I'm saying. She came to me for something
Okay.
else, which I'll show you. But this was her primary X-ray.
Yeah. So
This, what you would do?
So I would immobilize this in pronation, Sandeep. This is what I've seen.
Okay.
That you immobilize
But
that.
conservative.
Yeah,
right?
we can conserve, but see again, we need to understand if you just immobilize in supination, this I have seen translation after plaster. So this will get complicated. But if you immobilize in mid-prone, then it would stay like this.
No, okay, that's fine. So what I'm asking is conservative treatment, no
Yeah,
treatment.
conservative treatment,
Yeah,
yes.
okay.
Yeah, I mean,
This
considering the
she was
X-ray,
treated-
everybody will feel that.
See, this was treated in plaster. And see what has happened.
Synostosis kind of thing.
Yeah, she came to me for this problem. And she had no pronosupination. So the radial head still looks nice. Yeah. But that shaft has cross-united to the ulna. And this is without any intervention. No wire, no reduction. Just a plaster was given by the primary treating surgeon.
So Sandeep, if you see this, this happens sometimes because now if you trace the outline of the shaft,
yeah,
there is more translation than
exactly.
which was
So
earlier.
that's what I was trying to point out, that it is the shaft which goes towards the ulna.
Yeah.
Very often, and what we take as angulation of the radius might be translation of the shaft. We don't take that into consideration.
And then Sandeep, what happens is there is an interosseous membrane gets ossified.
Yeah. There is some injury to the interosseous membrane. It
Yeah.
can get ossified. So please don't go away thinking that conservative किया तो सब कुछ ठीक होता है. All radial neck fractures can be troublesome.
नहीं संदीप, मैसेज हियर आपको बहुत क्लियरली देना है कि यू immobilize in mid-prone and that this translation would not happen.
नहीं, मेरे को इतना मैसेज देना है कि radial neck fracture is tricky. It is not very straightforward. Otherwise, बहुत ज्यादा हम लोग conservative कभी-कभी उसके बावजूद भी ऐसा हो सकता है. तो तुम काउंसिल ठीक से करो.
Counsel the parent, yeah, exactly, Sandeep. Yeah, so you have to counsel the parent that all these things can happen. Even you do this, but avian can happen.
So, and try to be as I'll go ahead.
Yeah.
So this again, I had put this as an interesting case. What we and this was the synostosis that and all. And ultimately, we resected synostosis in congenital radioulnar synostosis. I'm not too much of good results with excision of.
संदीप, आपका आवाज ब्रेक हो रहा है. I don't know whether everyone is experiencing this.
Yeah. Voice is breaking, Sandeep.
Okay, can you hear me now?
Yeah.
Yes, sir.
Okay, I'll go slow. So what happens is that in congenital radioulnar synostosis, excision of the synostosis is not shown to give great results. Derotation osteotomies may be better. In traumatic synostosis, you can go ahead and resect the synostosis and put a fat graft, which is what we did here. And that gave us very good results. This was the case where we excised that synostosis and restored the range of motion. On table, it was complete range of motion, and that has been retained over a period of time. This was put in a slab. We put fat. I put bone wax and then put a fat graft in between to prevent reossification. And this girl is now at 2 months post-op. She's got her full range back with full pronosupination, and they're quite happy. So this was just to highlight the thing that even conservatively done cases, there can be trouble, and these synostoses which are post-traumatic have been published and described, and you should be aware of those. Yeah, now let's have questions.
So Sandeep, I know the answer, but for the fellows, now there are certain radial neck fractures where the radial head is anteriorly displaced or the shaft has gone posteriorly.
Yeah.
And we know that posterior interosseous nerve goes from front. So how would you safeguard your intrafocal pin?
So every time you make that entry, no, you go close to the ulnar border from behind, front, and engage. Basically, you are entering the fracture. The wire should never go from front. Anteromedially, anterolateral entry is not acceptable. You go close to the ulnar border, and from there, it's you have to just make sure you enter the fracture state and then use that as a lever. You can lever both the head fragment or the shaft fragment.
Yeah. So the message is, if you should posterior interosseous nerve goes anteriorly, so your intrafocal pin should not go too much of anterior, otherwise it may damage. Sometimes people have used a bit blunt wire to, as Viraj has shown, as to do the intrafocal thing. Now, Harish has been asking a question, and I agree, Harish, that if you take only isolated AP view, you might see that displacement is little less. Just like SCFE, if you do a rotation or when you see under image intensifier, you will see the true angulation. And an X-ray, oblique X-rays, where you see the radial head as a rectangular piece or in profile, that is the actual displacement. What I have seen, some colleagues, they accept 30-degree angulation, but that is not a true angulation. So take oblique views and see the radial head in rectangular piece in profile and consider that as a actual displacement, and you might use one of these techniques to bring it to less than 30-degree, which is a remodelable angulation.
Yeah, and it's okay to use more than one technique. It's okay to to use a combination of techniques. Nothing is foolproof.
Yeah. So I just saw that many a times in younger children, in 5 days it starts gluing.
Yeah, coming up.
So you do this osteoclysis thing, put a wire, and then you reduce it. So Harish, can you tell us about this coils view? I'm not aware about this. Is just the rotation view of or internal or external oblique? What is it?
Basically, it's a oblique view where you keep the limb on a table. You flex the elbow to 90 degrees. Okay, and you shoot the X-ray beam at 45 degrees. Basically, the forearm is in supination. It is helpful in cases where children are not able to extend the elbow. So your elbow is on, the limb is on table, flat on the table. Elbow is at 90 degrees. You try and supinate so that the thumb is pointing toward the ceiling, and you shoot. The beam is projected at 45 degrees.
Yeah.
So it will give actually good view of capitulum as well as radial neck. Sometimes it can be used also for Monteggia lesions to assess the reduction.
In my, this reduction techniques I have been doing, what I have seen, the radial neck would look in profile when you do internal 45-degree pronation from the full supination. So it's kind of internal oblique view of forearm will show you the true angulation. Yeah. So PI and palsy post-op incidence in your series, Sandeep sir and Viraj sir. Sandeep, you want to comment?
Yeah.
Any incidence of PI and palsy?
No.
Sorry, I didn't. I was not paying attention.
Rajiv's question: what is the incidence of PI and palsy in your series? But
no, nothing. Zero.
Nothing.
We, as a part of iatrogenic complication, zero. But fracture dislocations, you can get it as a preoperative.
I think he's asking about iatrogenic. So if you safeguard, as Sandeep said, you pass wire from posteriorly on the ulnar border, it will not produce. So it is a valid question that we should avoid PIN. Yeah. Any further questions? Metazu का complication नहीं दिखा संदीप भाई. I have
so like I said, I don't do Metazu routinely.
Yeah.
My intrafocal works well. I don't additionally stabilize. And this was a 3-week old, and I was not getting full reduction.
Yeah.
So I was a little keen to try that also, and I have done it a couple of times only. I'm not a very big fan because I'll tell you what, it adds another incision distally. And the parents sometimes are saying fracture to idhar hai, operation kidhar kiya hai. In addition to that, second problem of implant removal is there. This pin I can pull out in the OPD by making a window in the plaster.
Yeah. The second thing with the metals, I have seen a few cases where it has penetrated the articular cartilage.
Yeah. It's not a very easy thing. Huh?
It's not. easy thing. And the length of this nail, you have to, the cutting of nail precisely over the flare is also an issue. And yeah, upper one is going to be okay. Thanks, Harish.
Yeah. So all in all, this is a very, very specialized fracture, and it should get some more attention that it deserves, and try to be as conservative and minimally invasive as possible.
Yeah, because the complications most of the times are associated because of the trauma itself. I mean, the fracture is severely displaced. So already the vascularity is gone. Suppose the periosteum also has stripped to a great extent. So whatever you do, you can land up with AVN. That is one. And secondly, what Sandeep has also mentioned, that cyanosis is another problem when you get a very, very severe displaced fragment, and when you try to do best reduction and whatever there, but then you should be still prepared for the cyanosis that is there.
One thing I would like to tell all these colleagues is, many a times if you do clinical examination well, you will know that this is an isolated radial neck fracture. So isolated radial necks, I have seen the swelling and tenderness is only on the lateral side along the radial neck. When it is associated with elbow dislocation, which is spontaneously reduced, you will see the tendon on the medial as well as posterior side. So you have to be ready for some intervention. If it is associated with elbow dislocation, there's an unstable situation, and you have to fix the radial head most of the times either by a wire or a metazu. So you should have an idea that this is not a simple fracture. This might get complicated. Sometimes there is spontaneous relocation of elbow, and you are under a misunderstanding that this is isolated radial neck fracture. So I think, Joannes, we can conclude the session. Thanks, Sandeep and Viraj. Viraj was here, Sandeep, by yesterday, and we went to Riverfront and we remembered you.
Yeah. I know your congratulations to Goda Shri if she is around for passing.
Thank you, sir. Thank you so much.
100% result.
Congratulations, Goda.
I was at Vairok yesterday with Taral and Rojuta.
Yeah, we saw the photo.
Came back late night, and then that's why I was not very sure whether I'll be able to. But then I can't resist.
And Viraj also traveled. Viraj reached Nagpur last night late, and still, so I'm very thankful to.
Prepared to talk during flight, thanks to the Indigo people. So I could prepare.
And when your name comes, Sandeep Bhai and Viraj, see a lot of delegates. They would like to attend, more than 30 people in the morning.
Yeah. Thanks to all delegates.
Okay, bye.
Bye-bye, Molin. Bye, Sandeep. Bye. See you. Bye-bye.